So this is slightly different. That was more on quality of patients and their involvement in decision making. This second talk, composite outcomes, is actually what it is. Most clinical trials no longer report one outcome, but a combination of outcomes together. Whichever happens first is taken as an event having happened. So this is when you do randomized control studies or even cohort studies. Whichever of a multitude of outcomes happens first, it is taken as the outcome has happened. So today's talk is on a slightly different approach. It's not new, but it's little new for us. So I'm going to talk about something called win ratio, net treatment benefit, and success odds. So first of all, I must acknowledge that uh, I was asked to give some talk to another department on critical appraisal of an RCT, and they were asking like, what about the win ratio and net treatment benefit? So I thought that opened my eyes to read more about it. So this article is excellent. This gentleman, Stuart Pocock, he's from the London School of Hygiene and Tropical Medicine. This is a fantastic article for anybody interested. There's another gentleman, Johan Verbeek. He's also written a nice article on the same thing. So if anybody wants to read more about this particular topic, much of my material I have taken is from these two people. So that is the acknowledgement. So think about single outcomes. In most trials, single outcome means it could be dead or alive. So that's a single outcome. Or it could be hospitalized. Be hospitalized or not. Or hospitalized for what reason? For atrial fibrillation, for heart failure, for endocarditis. Quality of life, usually a score. It's not good or bad, some score. It could be a biomarker. The outcome could be the procalcitonin level, which we're using for infection. Or the outcome could be a composite of any of these. I'll give an example of a composite. In 2012, this, I remember at the beginning, there's an outcome called COMET, which is looking at composite outcome scores in different. So major adverse cardiac events was defined in 2012 to be any one of acute myocardial infarction, stroke, or cardiovascular mortality, meaning you died because of a cardiac event. Then a few years later, they added on a fourth one, hospitalization for unstable angina or revascularization. And a few years later, they added a fifth one, heart failure hospitalization, or if you develop heart failure. So now if you put MACE, any one of these outcomes is called a part of the composite outcome. So this is called a composite outcome. So I just Googled yesterday, not Google, I went on PubMed and I put the word composite outcome in randomized control studies. Okay. And you can see that all of a sudden, starting, that is 1979, the graph begins. And I don't know if this will work. 1979. And as time goes on, you can see all of a sudden now is an explosion of randomized control studies, which are all reporting composite outcomes. In 2024, 1,100 randomized control studies, all of them have the outcome as not a single outcome, but as a composite outcome. So this composite outcome is an important thing to learn. When you look at these composite outcomes, so this is a trial comparing empagliflozin with a placebo, and the outcome, it looks like hazard ratio for survival. So one would think the outcome is mortality, single outcome, but actually it's not. It's a composite of cardiovascular death or heart failure hospitalization, whichever happens first. So you start off with people not having an outcome, and every time you have either a death or cardiovascular death or hospitalization, you go up. So the blue line is placebo and the red orange line is empagliflozin. It's the same graph, this blown up, and the hazard ratio suggests that empagliflozin reduces a composite. So people may think it reduces death, but it may actually be the heart failure which came down, not death, whichever happened first. And as clinicians, people will be admitted for heart failure hospitalization and then die. So you can see automatically a problem happens when you do a composite out. I hope that's a little bit as an introduction to the topic. So if you decompose that previous trial, this empagliflozin versus placebo, you can see that the primary outcome is a composite. But if you break it down, heart failure hospitalization was 259 versus 352 on this side. and then cardiovascular death is 219 and 244, right? But 148 cardiovascular deaths after hospitalization don't get counted, because if your first event is a heart failure hospitalization, the subsequent death is not counted. If you had one hospital heart failure, you may get another heart failure a month later, admitted again. That's also not counted. So you can see that this, when people have repeated events, the next event never gets counted in this particular methodology that we do for composite outcomes. So it's always a time to first event. It's a composite of death, cardiovascular death, heart failure, stroke, non-fatal MI or MI. All are considered as equal, and the second event is ignored. That's a summary of the problem, which why I'm taking this particular topic. Now coming to win ratio. Now this is another statistical method. It makes outcome ranks. So like you say, first rank, second rank, third rank, somebody with high in nephrology and got a good rank. The rank is based on clinical priority. Clinical priority means patients, caregivers, doctors, administrators, economists will say, okay, this is the order of the most important outcome, next important outcome, and least important outcome. So you must make clinical priorities. Here are some examples. Instead of just saying that only death or hospitalization, I'll say I'll give priority to death, and then I'll say the next important is heart failure hospitalization. This is time to first hospitalization. Instead of time to first hospitalization, I can also say death is the most important. The second one is number of hospitalization. Number which somebody could be admitted once for heart failure, somebody 2 times. A third way of looking at it is time to death, then time to stroke, time to MI, time to coronary leave. So then this is the most important outcome, second most, third most, fourth. This how do we decide? Importantly, before the study, a group of clinicians, experts must get together and decide this is the priority of outcome. And this is another one. But the important thing you see here, we can also add quality of life. Or we can say a biomarker. So any outcome can be added when we do this particular win ratio method. It need not be yes or no death. It could be time to an event, which is survival. It could be a biomarker. It could be a quality of life. So you can have any type of outcome in a win ratio methodology. Only thing is that before the study you must rank them. All the experts must sit together and decide this is the order of priority of outcomes. Right? So each patient in an intervention, suppose you have a randomized control study. You have intervention on comparison. Like Anuka's talked before. There were some people who had a PDA, some people who had an EDA, some people who had both, and some people who had none. So each patient in the intervention arm is compared to each patient in the control arm. You compare the wins. That means when the patient in the intervention arm does better, that's called a win. When the person in the intervention arm does worse, it's called loss. So you add up all the wins and all the losses and you make a ratio of them. So it's a very simple concept actually, this win ratio. So let's look at this, a trial of A and B. Black is death, the triangle is hospitalization, the arrow is censored, means nothing happened at the end of the trial. So let's just have an order. Let's start with Anu. Who wins in these two? So because A didn't die, but A was going on, so A wins on death. Between these two, you see, A got hospitalized earlier, but B died. So if you take death as the outcome, A wins on death, but A got hospitalized earlier. So A wins on death. Right? So like this similarly, here also A died, but A died later. Then the next one, hospitalization. Okay. Here who wins between these two? Mercy.
Hospitalization, no, A.
A wins. Here also A wins, but A died.
Death.
That is not counted because we took only the first event. Here
No. I mean,
A wins, so nothing happened. Okay. Then we like to take this one. tile. Nothing happened to anybody. Here, that here, but you can, if the outcome was measured at this point of time, it will be called a tile. Similarly, if you thought of death as the major outcome here, you say it's a tile because nobody died till the end of the study. We got a general idea of how a win ratio is done. So in the conventional example, who would have won between A and B? Let's ask what is who would have died? Time to first event, A or B? B won because he didn't have it. Time to first event was here, whereas A got the first time to event here. Suppose I go to win ratio method for death, and death is the most important outcome. Who wins? A wins because B died. He never died at all. You can see how suddenly we make a priority of outcomes. The win and loss suddenly changes. So that's important way to think about this thing. So let's look at one more example before we go on. So the triangle is a non-fatal MI and death is here. So who won here? Time to first event, who died? Who won? C1 because this one happened. But if you took death, E1. Example 2. Now look at this. This is disabling stroke. This is urgent revascularization and death. What happened here? We call this a tie because both of them had event at the same time. So survival analysis, both of them will be out of the story at the same time. But look at this guy who actually did worse. C did worse and actually E1. When you have multiple outcomes, you must consider that, oh, this is something to keep carefully in mind. Is that okay? Everybody all right? Oh, okay, this trial got a bit cut off. So this is a trial looking at Mitra clip for patients with heart failure. Unfortunately, that has got cut off in the back. I'll put it up later. So people with heart failure and mitral regurgitation, you can use a device called a Mitra clip, or you can try medicines alone. And the device appeared to do better in the Mitra clip group. Is a device group and the control group. This is the usual presentation for randomized controlled trials, time to first event. So I just want to show you. So let me ask you again. See, there were 302 people in this group, 312. Each patient here can be compared with each patient. So then you'll say that 302 into 312, there are potentially 94,000 pairs. So we decided that death is the most important outcome. Second most important outcome is heart failure, hospitalization. How did we decide? Some group of experts are together. So let me ask, Nishi, what happened on death? Who won more? The Mitra clip arm won 27,000 wins. It had 18,000 losses. Tie means those 48,000 pairs, nobody died. So overall, on death, who won? Can you take the second one? So the person who goes to the next group is not the people who died or did or lost. Only the ties goes to the next group. So what happened on ties? What is your opinion? Ties. Who won on ties? The Mitra clip arm got 15,000 wins and it had 7,000 losses. At the end of the study, there were still 23,000 people, nothing happened. So this win ratio also tells you that at the end of the study, many people, nothing at all happened. So what is the win ratio? If you add 27,000 plus 15,000, it comes to 42,000. If you add 18,000 plus 7,000, it comes to 26,000. The ratio is 1.61. So it's a ratio of a new patient who comes, because the potential chance of victory is 1.61. And this Finkelstein-Schoenfeld method, that is a statistical method to calculate the confidence interval. It's quite simple actually. Once you get the idea of it, very intuitive to use this win ratio method. Now, another statistic which some people give is called win difference. So, if you put this 27,000, what is the percentage of the total here? And 18,000, what is the percentage of the total here in this group here? That is 27% of people had a win here, 19% here. So the difference of 28 and 7 is 19 is 9%. Here it is 16%, here it is 8%, so 8%. So the wind difference in favor of the mitra clip is 17%. It's just the same number. Some people ask you the wind difference, some people ask the wind ratio, just to explain that these are two different numbers. So, just to tell the same thing, if one or both patients die, if a patient in treatment group dies, then the control wins. If the patient in the control group dies, then the treatment wins. You understood that? That's how you get this win and loss. Some people may be confused. If both die on the same day, what do you think? Die or death. If neither of them die, die. You go to step 2. The second step is stroke. If patient in treatment group has a stroke, control wins. If the control group has a stroke, treatment wins. Stroke on same day is rare, can happen, time. No stroke, next group. So we have a next group, heart failure hospitalization. If treatment group has more hospitalization, control wins. Then you go the same way. At the end of the trial, you will be left with many studies. So this is another trial. I'm just going to go through many examples so that we learn this part. Tafamidis is a drug for people with amyloid cardiomyopathy. It's a new drug. Not new. The study has come out in 2018. So they did 441 patients, 264 in tafamidis, 177 in placebo. So how many pairs are possible? Each one here against each one. So 264 and 177. So you all understood how we make a pair. So the primary analysis is called hierarchical. So what is this fancy word hierarchical? Hierarchy means a hierarchy of order of. So that is all-cause mortality, then cardiovascular hospitalization, and they use this. Whenever you see this method, Finkelstein-Schoenfeld method. I don't know if my pronunciation is right, but that is usually when you're using the win ratio. So they said that using the win ratio was 1.71 in favor of the family. So this is just taken from the NEJM paper. So increasingly win ratio is being reported even in good journals. And the p-value is given here. Now, just to say that if you look at people with cardiomyopathy, they can have New York Heart Association 3 or 4, that means they're quite breathless, or 1 or 2. And the transdirectin gene could be wild type or it could be a variant mutant. So now you can even do subgroup analysis. So you can look at people with class 1 or 2 heart failure or class 3 or 4 and variant and wild. So you can subgroup the patients into 4 separate subgroups. So you can have 34 to 24 year pairs, 29 versus 19 pairs. So total 17,000 pairs. So I hope I have not lost anybody so far. So then now because I have how many groups here? 1, 2, 3, 4. So now I've got 4 subgroups. I can put up a win ratio picture for 1, 2, 3, 4. And the overall win ratio is a summary of all 4 win ratios of this subgroups together. Understood? So we can even do grouping or stratified win ratio. It's not just an overall win ratio. There's a stratification of this group is NYHA 1 and 2 and wild type, NYHA 1 and 2 and variant, NYHA 3 and wild, 3 and variant. So in each group we'll have wins for death and wins for heart failure. So you get a win ratio for each one. So one of the important thing about win ratio when we do statistics is that there should be something about independence. Each outcome is independent of the next outcome. Win ratio takes care of this independence issue. Okay. Now the next one. SGLT2 inhibitor empagliflozin for patients with heart failure hospitalization. So just remember, a drug for heart failure hospitalization. And then they mentioned in this particular paper that it's a hierarchy. So hierarchy means somebody's had made an order of priority. The most important, next important, next important. See, Kansas City Cardiovascular Questionnaire is a qualitative questionnaire for people with heart disease. Oh, the score. How do you know who did better on a score? Like Anuka mentioned earlier, the score you must know the total score. Is better, higher score better or lower score is better? Plus, everybody who develops a score should tell you that a change of so much is meaningful. These people have said that a 5-point change in the Kansas City score is meaningful, right? So this at day 90. So they said when the score will be done of the score, if anybody has a change of 5 points, that means somebody won, right? So 265 to EMPA, 265 to placebo. So how many groups? 265 into 265. So sometimes people present a picture without the earlier picture which I showed you is like this. This is sort of intuitive and easy to understand. Some people present, this is actually from the paper. This is another way of showing you. So the overall win ratio, 53% wins for the EMPA, 39 losses. So the win ratio is 53 by 39, which is 1.36. You can even show it as a graphic. Favors EMPA, favors placebo. So this is the graphic representation of win. Then you can say the time to death. So instead of showing you like this, death, cardiovascular, like that, they have shown it like this way. Another level. So on the death, how many were there? Heart failure, hospitalization, win and loss, time to heart failure, Kansas City. So you can see that majority of the win ratio was contributed by the quality of life, right? And then there were sort of ties left over in the end. So this also you can tell you the contribution of each component of your win ratio, how much it is. This is a nice graphical representation from the paper. Yeah. Okay. This is the same thing. Somebody likes to see like this, somebody likes to see this way. So you can see that death 7%, 4%, heart failure events 10, 7. Time to first heart failure event is very small, but much of the win ratio was contributed by the change in the quality of life. So this is an important way. The overall win ratio is 1.36. And you can also calculate a win difference at each point. And the win difference is 14.9 in favor of empagliflozin. Yeah. Now it's a bit of heavy starts to do on Saturday, but this is this. So we looked at deaths and quality of life into a single outcome. So the win ratio can capture everything together. But when you tell the win ratio, you must tell them what was the hierarchy of events and was quality of life part of the events. So it is a nice one. Other thing is missing data. So all of you know that missing data, people use some method of putting in data instead of deleting people with missing data. Putting in data is called imputing data. So in all these RCTs, there is multiple imputations. So the win ratio is the average of all the imputed methods. So the other thing, we can even give win ratio for subgroups. So for example, the same trial, the overall, remember 1.36 for empagliflozin. Then I can say for people with de novo heart failure, that means the first time they came with heart failure, empagliflozin doesn't seem to be so good. Whereas people who already had a chronic heart failure or decompensated, it seems to be good. So one can give subgroups, you can give breakup also of win ratios. So combining qualitative and quantitative outcomes. Clinical outcomes are not good enough. So now you see that most randomized controlled trials of cardio, infection, other things. The new drugs don't actually reduce mortality much. You've already got the mortality benefit from so much treatment. Additional mortality benefit is very low. That's why sample size also become mega. All cardiovascular trials with 10,000, 1 lakh people. But now if you can add more outcomes like this, where including quality of life, then it adds to the value of the paper. So quality of life will add to power because more outcomes are going to happen. So quality of life alone may not be enough. So win ratio handles death as a competing risk because now you have given death as the first priority and that. So win ratio handles death also in qualitative studies. So here's what dapagliflozin for heart failure. Now this most of the papers are taken from the two authors which I mentioned. They are working in cardiovascular trials. So it appears that all win ratios in cardiovascular trials it's not. I'll give you another example. So here we got dapagliflozin versus placebo. So see how they are publishing nowadays, hazard ratio or rate ratio or win ratio. So you have to be a bit careful. Hey, where is this win ratio there? So can you see? Mean change in KCCQ score at month 20 at month 8 among survivors. This win ratio was calculated. This was calculated using the win ratio method. Everything else is hazard ratio. Here they have put it as a win ratio. So you can see that if you look at, depth from any cause, the p value is the hazard ratio was 0.94, and for among the survivors, the p value was 0.0001. That is death from any cause. But if you look at the win ratio method, the p value becomes a little bit less. So the win ratio method gives you a more accurate or better reflection of quality of life. It adjusts death as a competing event. So somebody just gives you quality of life p value, ask, have you adjusted it for a competing risk of death? That is the win ratio method. So it's even good for interpreting quality of life score. So you must understand which outcome is driving results. So you can see that I showed you. In most of the trials, death is hardly anything. Then the heart failure hospitalization contributes a lot. And then quality of life contributes largely. So when you're looking at the win ratio, you must not say, the win ratio suggests death is less. You should not make that wrong conclusion. Because death may not have contributed much at all to the win ratio. So look at the win ratio diagram. Look at it. What is the quantitative? So another problem is this. Suppose the new drug is in favor of death, meaning deaths are less in the new drug. But quality of life is worse in the new drug. Then you're left with a bit of a problem. We're all hoping that everything goes the same way. The new drug has less deaths, better quality of life, better biomarkers. But if some of these outcomes go in different directions, then it's a little bit of a problem in interpreting the win ratio. That's an inherent problem in a win ratio. Okay, now some more maths. So net treatment benefit. So many trials now report net treatment benefit. So the net treatment benefit. So NE in this formula is wins for the treatment group. NC is losses for the or wins for the control or losses for the treatment group. You understood that? You had a formula equation, no, wins by losses. Here in this formula, just remember that you're doing a difference. Can somebody tell me what this is? Wins minus losses? Win difference. So what I was calling win difference earlier, they put it as NE, which is wins minus losses. And the new denominator is everybody. Wins, losses, and ties. This formula is called net treatment benefit. So many clinical trials will say, what is the net treatment benefit? It's simple. The win difference divided by everybody. So it ranges between -1 and +1. The nice thing is somebody reports win net treatment benefit. 1 divided by the net treatment benefit is the NNT, or the number needed to treat, which we are going on harping about in all clinical trials. So a positive value means positive treatment effect. Negative value means harmful. So it's a probability that a random subject of the new treatment would do better than a random subject of the control minus the result. So this just remember that the same number only, there's a win and a loss. If you -1 from the other, it's called win difference. If you -1 from the other and divide it by the total number of wins, losses, and ties, it's called net treatment benefit. If you just divide the wins by loss, it's called win ratio. So that so far we're okay. Anybody confused? No. So the inverse of net treatment benefit is NNT. So win ratio, remember, is NE by NC. Win ratio can be from 0 to infinity. Just remember that a ratio can always, depending on where the 0 is, if the 0 is on top or 0 is below. So any ratio could be, the overall value could range from 0 to infinity. It is interpreted like an odds. Higher the win ratio, the better for the treatment. Less than 1 win ratio means harm for the new treatment. Win ratio 1 means there's no benefit or harm for the new treatment. This is the interpretation of win ratio. So more than 1 positive, less than 1 negative. The last bit of mathematics is called success odds. So what is success odds? So you can see that success odds formula? Basically it's NE by NC, which is the Wind ratio. Then people ask wind ratio, what's the big problem? What happened to the ties? You ignored the ties. So then somebody said, let us do a fancy maths. We put half the ties on top, half the ties below. So it's not that clever an idea, but it's a nice neat idea. So now we're not ignoring the ties. So success odds basically wind ratio with half the ties on top, half the ties below. Again, it could be 0 to infinity because it's a ratio and it's interpretable like a odds. So this is called success odds. Any questions? You may sound a bit mouthful to learn many new things. So we learn win ratio, win difference, net treatment benefit, success odds. Yeah, all clear on this. So more than one positive, less than one negative treatment effect. This is success odds. So let's look at two trials. This is taken from the papers by Dr. Varpi. This is trial 1, this is trial 2. In trial 1, there were 3 wins, 1 loss, and 4,996 ties. So clearly that's not a real life trial. In the second trial, 3,000 wins, 1,000 losses, and 1,000 ties. Do you notice anything about the ratio here? Wins to loss ratio? 3:1. 3:1. So the win ratio is same. Everybody understood that? Well, the win ratio just looks at wins to losses. It doesn't think about the ties. Okay. So few wins and few losses. Okay. Lots of ties. More wins, more losses. Lots of ties, less ties. Because there are more ties here, when you calculate the net treatment benefit, it appears to be small. Whenever there are a lot of ties, the net treatment benefit appears to be small. Here the same kind of data, but there are less number of ties, so net treatment benefit appears to be larger. So this is an interpretation of net treatment benefit. Same win ratio, right? Has anybody got a doubt on this? This is the basic part of it. How net treatment benefit is calculated, success odds are treated, win ratio is calculated. So lots of the worry people have of win ratio is what happens to the ties. So I'll just explain a little bit of that. Now the same slide as this, I'm just explaining another one. Actually, what win ratio does, this many people don't agree, but it does is it distributes the ties. So the win ratio distributes the ties in the same ratio as the wins and losses. So let me see if somebody can remember. Do you remember the ratio of wins and losses? In this 3:1. This is 3:1. So success odds just divides the ties half to the wins, half to the losses. But win ratio, what it's actually doing is in this 3:1 ratio, it's distributing all the ties. So it just put 75%, sorry. 75% of this net treatment of the ties are put into the wins, 25% are put into the losses. Similarly, here among the ties, 750 will go here, 250 will go here. So that is actually what is happening in a win ratio. It does not ignore the ties, but in the same ratio of win and losses, it puts people back into the equations. So now we have different types of outcome. Continuous outcome, let's say the outcome is blood pressure. Do you think that 2 patients will have the same blood pressure on time X? At the same day, one intervention control patient will have the same BP? But the chance of having ties in a randomized control by continuous outcomes is less. So people are very comfortable when there's a continuous outcome having a win ratio as the outcome methodology. Any measure can be used. Win ratio, NTB, net treatment benefit, success odds, all are same when the outcome is a continuous outcome. Suppose it is deaths. Is there a chance of 2 people dying on the same day? Maybe. And what about nobody dying? Then there will be a tie. So that's a problem with the win ratio. So then people say that, oh, win ratio not so great, let us use net treatment benefit or success odds if lots of the outcomes is death. If survival, chance of having died, chance of dying on the same day not high, but a lot of sensors will be there. Nothing happened to those people at the end of the trial. So again, you think that win ratio assumes that people who are censored will look, the data will look very similar to those who are observed, which is not true because if redistributing the, remember, win ratio redistributes the people with ties into the win and loss, assuming the same thing is going to happen to them, which may not be true in a survival analysis. So that's a little bit of a problem if you have survival type of data. Okay, now you all are familiar with this kind of a picture, survival analysis. So what happened? These are two drugs. Again, I've taken this from the papers which I mentioned in the beginning. This is a control and that is intervention. It appears that the intervention is doing better at 1 year. Yes, everybody can see that. So this is everybody alive at the beginning. As time goes on, people start to die, and the survivor 100% alive. At 75% of people are still alive, and you can look at the two different times between the two groups. At 1 year's time, there's a difference of about, let us say, 10% difference in survival. Everybody understood this survival curve? Is okay or too confusing? It's okay. Okay, that's all. Again, it was very important. Everybody alive here. As you die, you go down the curve because you're dying, and the probability of 98% being alive, 98% being alive means 2% dying. That's called survival curve. Yeah, everybody should understand that. It's not that everybody was alive and as they die, they go up. This is reverse of that. Everybody's alive. As you die, you go down the curve. And over time, the red curve, by 1 year's time, let us say that is 70 or 60. Let's say 70. That is 30% of people dying. In the blue curve, let us say that is 55. So what percent died? 45% of people have died, 55% of people still remaining alive. So at this point of time, at 1 year, the net treatment benefit is 0.07, success odds is this, win ratio is 1.24. One by the win hazard ratio is also very similar to the win ratio. So somebody asked what's the relationship between win ratio and hazard? There's a sort of a relationship between them. 1 by the NTB is the number needed to treat. So this is also a neat thing that you can use in this. But remember that people who didn't, after this point of time, they're all censored. Censored means we're not interested in what happened to them. We cut off their data. They didn't die, they're not part of sort of censored data. Now, one of the rules of survival analysis is what? Anybody can tell me? Proportional hazards. Proportional hazards means the rate of death in this arm must be the same as the rate of death in. So the proportion, the rate of the different hazard should be the same. Now look at this. So when we censor here, we assume that at a future time, the same difference is going to continue. That's the assumption. When we stop at a point of time, future will remain the same as what happened then. So what do you think about this one? We censored here at 1 year. Here we censored at 2 years. Is there a major change in the net treatment benefit, success odds, or win ratio? For 1 year and 2 years, there's no major change because the curves look very similar. So the proportional hazard is maintained between 1 year and at 2 years. If proportional hazards you think in your clinical situation will be maintained, then the 1 year when you do censor, you're not very worried about what will happen in the future, right? Nobody is worried. Because of constant hazard, win ratio at 2 years, same as 1 year. Now look at these two. This is 1 year and this at 2 years. Let me ask, do you think they are same now? Why not? Because the curves are diverging. The proportional hazard assumption, we thought the curves will remain same. Like this, the curves remain almost the same at 2 years as well. That is proportional hazards. But actually what happened was the curve started diverging. So you can see the net treatment benefit change, the win ratio change, and the success or change. So there is a type varying hazard ratio. So win ratio is not the same. So you must be careful. You must be the doctor or healthcare person or statistician. You must think, okay, is it likely that the same difference is going to continue? Will the hazards remain the same or there will be a change? If you think there's a change, then you must tell the reader that the win ratio may change in subsequent time because the proportional hazard assumption may not work. Clear? Okay, the next one. What is this? We are very happy. What happened here? Now there's a problem. At 2 years' time, again there's a change in the win ratio and success odds and net treatment benefit. So there's a crossing win ratio not the same. So if you think that this may happen, suddenly after some time, initially a group starts doing very well, like tortoise and hare, what do we say, rabbit and the tortoise story. The rabbit goes very fast, after some time it sleeps and then the tortoise catches over. I'm just saying, it may happen that in clinical trial, one arm does very well in the beginning, after some time the arm starts to do badly, and the other arm. Then we should be careful about this win ratio business. Okay, I told you that I was going on about cardiovascular. So this is a particular trial called Merino. Anyway, for the interns, residents, nowadays people like to give mnemonics for their clinical trials because people will. Answer?
Yeah.
Joel's Bluetooth will pair.
One.
Okay. Never mind. So this Merino trial looked at people with Klebsiella infection, which was resistant to ceftriaxone. So Klebsiella infection, resistant to ceftriaxone. So in C1, we often give piperacillin tazobactam. Some people give meropenem. So this is right up our alley in general medicine. We see a lot of infections. A randomized trial comparing two antibiotics. Can we use the win ratio? So Shruti, what will be the first thing to do? Okay, so you have, let's say 100 in each arm. So 100 into 100 pairs. Second, make outcomes. What should you do with the outcomes? Make a hierarchy. Exactly. So what would be the most important outcome for you? Okay. Where would death come? Death. So you have many outcomes, which is really the most important outcome. So some people may say death, then quality of life, maybe duration of hospital, maybe even bill, so many things. So I'm just saying, all a group of people must sit together and decide the hierarchy of events. Let's see what they did. So what did they choose as the number one outcome? Death. Second, microbiological relapse. Oh, if I give piperacillin tazobactam, they may not die, but after 2 months, they may come back with relapse. The third one is secondary infection. You are admitted in hospital, you may land up getting a. You may not agree with this hierarchy of events. You may say they should have some more outcomes. But this is what the people in the Merino trial decided was their hierarchy of events. So exam, they also given, no? If you win, you go here. If you lose here, if you tie, then you go to microbial relapse. If you win, you go here. If you lose, you go here. If you're tied, you go to secondary infection. Win, loss, and tie. Number of wins by number of losses in the win ratio. Yes, so everybody is familiar with win ratio now. And this is the publication from there. So you can say they also told. So it's 30-day all-cause mortality. Sounds like a mouthful. Basically, you're dead in 30 days or not. So more losses, less wins. Relapses. This is piperacillin tazobactam. This is meropenem. So there's no. So this is 1.8 relapse. This is 3.6. So secondary infection and secondary infection. And then final result 7.5% wins and 19%. So the win ratio was 0.45. Right. Correct? And then you can put a win odds or success odds. Some people call it success odds, some people call it as a win odds. We can also do win difference. So we can do the difference here. Win difference. So this is just to show that we can do even a clinical trials of infection, any randomized controlled trial, as long as you can make a hierarchy, then you can do a win ratio. You can also do some, I just want to tell you that, see, this is the hierarchy involving 1, 2, 3 outcomes, right? What will happen if you add a fourth outcome or a fifth outcome? So look at this. This has how many outcomes? All-cause mortality, relapse and secondary infection, 3. So the win ratio was 0.4, correct? If you add length of hospital stay, suddenly the win ratio changes. I remember yesterday we were discussing subgroups also we can do. Among those with hospital-acquired infections, non-hospital acquired infections, urinary tract infection, non-urinary tract infection. So we can even do win ratio for subgroups which are usually predetermined. If you predetermined it before the study was begun, you said I will see subgroups. If you didn't plan it and did it after the study, we generally call it sensitivity analysis because we never thought about the idea before. After seeing the data, you got a clever idea and you did sensitivity analysis. So now the next one. I just want to show, okay, this you can't see, sorry, radial versus femoral axis. So let us say Emil is doing a trial in cardiovascular and people with MI, heart attack. And previously when I was a resident, we used to put the catheter in the femoral, whereas now people put catheter in the radial artery. So convenient for the radial artery. Mortality won't change, but maybe bleeding will become less. So can we put a arm also as outcome? So this was called the matrix trial. So I just want to show you that. What happened to this? Here. So we have patients, time to death, time to hemorrhagic stroke, time to ischemic stroke, time to MI, bleeding. So you can include even arms as part of your outcome. So with the time to first event analysis, there was superiority of the net adverse clinical endpoints. So that when the clinical net adverse clinical endpoint included, when you put adverse event, they called it as a MACE. And when MACE was only I told you only the definition of MACE earlier. So when you put MACE, then the radial one looks better. If you just put MACE, both of them look the same. Why? Because MACE doesn't take into account bleeding. Whereas NACE, which is basically the win ratio, including side effects, which are major bleeding, it shows a difference. So the benefit of adding side effects or harmful effects, you use a win ratio. So for discrete outcomes, survival outcomes, caution with win ratio. I explained why. Right? Okay. Use net treatment benefit or survival odds of win odds if there is a survival outcome or discrete outcome alone. So now I'm not going to spend much time on the slide, just to explain that the statistics generalized pairwise comparison. That's what we're doing. Pairwise means we selected each person intervention, each person the control. One method is win ratio or NTB or success odds or win odds. Then one method is called win ratio. There are many methods of generalized pairwise comparison. And for this particular method, the statistics is called Finkelstein-Schoenfeld method. And this is the interpretation of these. Any doubt so far? Net treatment benefit, win ratio, success odds. The difference between these two is win difference. The difference divided by everybody, wins, losses, and ties is net treatment benefit. Win and loss ratio is win ratio. Success odds puts win ratio and puts half the ties here, half the ties here. So many people like the success odds. Actually, win ratio doesn't ignore the ties. Same percentage is put up here. All the ties are divided depending on the same ratio of win and loss. So now there is a guidance document. If you're using generalized pairwise comparison, only survival outcomes, yes, constant hazard, user threshold, absolute measure. So we don't have to go through this. Just to say that if somebody asks you, can you use win ratio, net treatment benefit, success odds in a clinical trial? Yes, we can. But you said there are some issues. There's a guidance document how to choose which one to choose as the particular outcome. So this just goes to that. For example, I say they're not, I mean, they're more than just survival outcomes. No. Categorical outcomes, no, you go this way. Categorical outcome, yes, you go. Interest in each outcome's contribution, yes, then you go to net treatment benefit. No, a favorable outcome measure, yes, you come here, no success. So it's just a method of thinking through. First, you make the hierarchy, then you must think about this one. Now, contribution of the components. Okay, now this is a trial in which there is death, stroke, myocardial infarction, and revascularization. And there are wins, losses, dies, net treatment benefit, success odds, and win ratio. So that you can see that focus only on net treatment benefit, right? Which of these had the highest net treatment benefit? Which outcome? Somebody mentioned revascularization. So net treatment benefit, if you add all the net treatment benefit, it will give you the overall net treatment benefit. This works for net treatment benefit. The total adds up. Second, individual components, total component, total adds up. Third, this is the number one. Which is number two? Slightly less. This is even less. 1, 2, 3. You can say from net treatment benefit, you can say which contributed more, which contributed less. However, you can't change the order of this. You can't say and then expect the same thing to happen. All these assume that the hierarchy is fixed. You can't say that if I change the hierarchy, I'll get the same win ratio, net treatment benefit, success rate. This is the hierarchy: death, stroke, myocardial infarction, revascularization. So you should be very careful when you're doing win ratio or all these GPCs. What is the hierarchy and was it planned before or after the study? You can start changing and saying which one gives me the result which I want. That we should not do. Now you see success odds also 1.09, 1. So remember NTP, which was the highest NTP? Revas. Then we said myocardial. Then we said this. And you can see success odds also 1.46, 1.23, 1.08. So you can rank the treatment or the outcomes based on NTP or success odds. But if you add up all the success odds, it comes more than the total success odds. Whereas NTP, you can add all of them, it comes to the total overall NTP. So we can't do that with success odds. Yeah, just to understand. This doesn't work for win ratio. You can see the win ratio is not saying that this is a number one for win ratio, and you can't add up all the win ratios and get the overall win ratio. This is just to understand the mathematics of win ratio, NTP, and success. Everybody okay? So, time to worst event. So, radial versus femoral artery, people undergoing acute coronary syndrome. Outcomes without bleeding and outcomes with bleeding. So, this is the incidence of bleeding with radial and femoral, femoral and radial. So, clearly there's more bleeding with radial. I showed you this picture before, the study before, but the bleeding with the radial is less, femoral is more. So, this is the same picture I told you earlier, just to say that in their hierarchy, death, stroke, ischemic stroke, MI, bar, time to bar. Yes. Wait, this got disconnected.
Oh, this last meeting.
Let's go back. So, important thing. My definition of major adverse cardiac events may be different from yours. So, in one of the previous presentations I was going through, that there are some 15 different definitions of stimulants reconnected, major adverse cardiac events. So you must be very careful when you see a study, MACE. Don't assume it's the MACE that you have in mind. You may think that cardiovascular death, a stroke, MI, but some other publication had a different definition of MACE. So you must be careful about what was their definition of MACE. Tell me when it's connected. Connected. Okay. So we are going back for the people online. Apologies for the delay. I hope you are all still there. Okay. Get back to this now. So this is the same study, time to worst event analysis. So we're looking at major adverse cardiac events. And I tried to explain that we must add bleeding. So you can see the maze here is slightly different. Time to death, it could be just death, yes or no. Or it should be time to death. If you say death, yes or no, it is just a binary outcome. Time to death is how long it took you to die. That's called survival. Right. So it's a survival outcome. Time to hemorrhagic stroke, time to ischemic stroke, time to myocardial infarction, time to major bleeding, and time to minor bleeding. What is this? This is called a hierarchy. Somebody sat and made a hierarchy and said, this is the hierarchy that we want for our trial. Benefit. Any number and type of outcome. Now, this is a study called the TAVR unload study. People with moderate aortic stenosis, which is a heart valve condition when the heart valve is blocked with heart failure. TAVR is a transcutaneous method of opening the valve and putting a new valve. Conventional treatment. Here we can look at survival. We can also look at other types of data. So there are people, 600 people who are randomized to TAVR or the normal conventional treatment. Here they looked at time to death, disabling stroke, disabling stroke. I don't know why they put two disabling stroke here. Number of hospitalization, length of hospitalization, and the change in the quality of life. So they made a hierarchy. So this is other thing is you can do something called simulation of the data as a trial is ongoing. So you can see what will happen when the trial goes on, what is likely to happen in the future. So they have given you some p-values which are likely to happen. So the log rank test looks only at survival. So when we do log rank statistics, whereas generalized pairwise comparison, which is the win ratio or the success odds or net treatment benefit, looks at all outcomes, right? So this is the log rank statistics, which is often given in a survival analysis graph. But now you can look at all three outcomes. This takes p-value takes into account all the outcomes. Okay. Now power analysis. This is the same slide which I showed you earlier: death, stroke, hospitalization, change in the KCCC cure. So the sample size required, if you just take time to first event, is 800. If you put generalized pairwise comparison, because many outcomes are being considered here, the sample size may be only 200. Right. So 4 times lower sample size with GPC as compared to log rank LR alone, because it has 4 outcomes including quality of life. So potentially, you should not do this because I can get less sample size. But if you think that the hierarchy of outcomes is important, you could get away with a smaller sample size if you do the composite outcome including win ratio. This is for summary. If you have multiple outcomes, time to first event is not so good, which is what every clinical trial has been doing till now. Win ratio, success odds, net treatment benefit is quite good. If you have more remember I told you on flow diagram how to choose, and everybody looking at it, squint eyed at me like, how do we go through the flow diagram? This is the same flow diagram in a table. If you have a lot of categorical outcomes, which means yes or no kind of outcomes, then success odds and net treatment benefit are slightly better. If you are worried about the relative treatment effect, comparing one versus the other, all 4 are good. Net treatment benefit is not so good. Absolute treatment effects, the time to first event will give you NNT, and so will the net treatment benefit. Remember, 1 by the NTB is the number needed to treat. Evenly redistributes ties, success odds and net treatment benefits evenly distributes the ties. Best under constant hazard. So time to first event assumes constant hazard, and win ratio also assumes constant hazard. I've shown you the picture that at future time points it assumes constant hazards. Additive effect of each contribution is only net treatment benefit. I showed you a table where you can rank the outcomes based on the net treatment benefit. And if you add all the net treatment benefit, it adds up to the total net treatment benefit. Interpreted as an odds, actually the success odds are most important to interpret just directly as a odds ratio. Right, but I know it's been a bit of a long session today, but any questions?